Good morning, everyone. And I would like to thank the organizers for giving this opportunity to me to speak on this very interesting topic of hyperkalemia, which is very, very important and significant in our day-to-day management of patients with a chronic kidney disease. And this, I would like to talk briefly about how the kidney handles potassium and what is the need of necessity of newer anti-hyperkalemic agents, and what are the existing agents and what are the shortcomings of them, what are the newer drugs available, and how to plan therapy for hyperkalemia. This is only one slide regarding how the potassium is being handled by the kidneys. And you know that the potassium will be freely filtered by the glomeruli, and 70% of that will be reabsorbed, reclaimed by the kidney in the proximal tubule, and 30% by the distal tubule. And it will be initially in the proximal convoluted tubule, it is just a free flow, and it is reabsorbed by the free renal tubule through the renal tubular epithelial cells, and it is not governed by any other drug or the substance or the hormone. And in the thin loop, it will be slightly leaked into the interstitium, but it will be reclaimed again by the thick ascending limb again, and it will be reabsorbed by the thick ascending limb and the distal convoluted tubule. Most of the hormones, especially the receptors, would be governing the entry and exit of this particular thing in association with the sodium to maintain electroneutrality between the sodium and the potassium. As the sodium is actually excreted into the tubule, the potassium will be reabsorbed and governed by the ENaC and also the ROMK channels. And the distal collecting duct also, it will be the same. Mostly, almost 2 to nearly sometimes 100% of the potassium will be excreted into the urine. Many a times, it all depends on the dietary potassium intake and the presence of several metabolic abnormalities like hypometabolic acidosis, metabolic alkalosis, and the hormones like aldosterone, which acts on the ENaC cell, and also sometimes vasopressin, which acts on the ROMK cells. So most of the times it also depends on the flow of fluid and also the flow of sodium into the distal convoluted tubule that determines how much potassium should be there in that. Especially when the kidney damage takes place, all these things will be deranged. Not only the hormones, but also the channels which actually govern the movement of potassium across the renal tubular epithelial cells. So that's why the handling hyperkalemia or hypokalemia in association with a chronic kidney disease is very, very difficult. Not that we see only hyperkalemia, many times we see hypokalemia also. But managing hyperkalemia is very, very difficult. You know that most of the patients would get into cardiac complications and other complications, and it would be one of the reasons for the early or emergency start of hemodialysis in those patients with a chronic kidney disease. Not just the kidney, but also the gut also involves in the management of potassium, and it's also gets reabsorbed by the small intestine and passively secreted into the colon, and but predominantly it is the kidney that manages the show, and many times the potassium also will be lost through the stools by almost nearly 10% of it. And a significant number of our patients will be having a chronic kidney disease alone as the etiology, but some of these associated features also can lead to hyperkalemia, the pseudo-hyperkalemia, the cellular redistribution of the potassium, especially in the presence of metabolic acidosis, which is an existing and part and parcel of chronic kidney disease, hypertonicity, insulin deficiency. Some of the drugs like beta blockers and alpha agonists can lead to, and some of our patients had hyperkalemic periodic paralysis on maintenance hemodialysis, and that is a recurrent periodic paralysis secondary to hyperkalemia we happen to see, and a massive tissue dissection secondary to rhabdomyolysis and the conditions also can lead to sudden occurrence of hyperkalemia, which should be managed very, very clearly. And many of our patients would not be able to restrict their potassium in their diet, and excess intake of potassium also would be one of the major reasons. And as we know that the decreased renal excretion, especially the oliguric renal failure, and some of the associated features with the kidney disease, mineralocorticoid deficiency, and the defects in the cortical collecting tubules also can lead to hyperkalemia. These are basically the etiology of hyperkalemia. In renal failure, many of these would really exist. And it is actually the basic understanding how to make a diagnosis of hyperkalemia or confirm the hyperkalemia and to manage or not depending on the ECG abnormalities, which we frequently follow, because many times it is actually the pseudo-hyperkalemia. Sometimes we might see when the patient is actually flexing the hand again and again with some exercise, and some of the dietary intake immediately makes a difference for him to increase the potassium in the levels in the blood. So, but many times we tend to take ECG and see whether the ECG changes are also there in association with the blood levels of hyperkalemia. So mild, moderate, severe changes in the ECG, and we get to see the tall tented T waves and the prolonged P and QRS complexes as the potassium increases to more than 8. You can see almost ventricular fibrillation, asystole, and bundle branch blocks and fascicular blocks, etc. But we don't really allow the patient to go till then, and we rarely see a patient who comes to us. And nowadays, with the drug therapies and all, we are able to control the potassium, and more awareness by the people to receive the potassium also is making the difference. And these are the drugs which are classically available for our therapeutic armamentarium of hyperkalemia management. These are the things which are known to every medical student seated in the chair in emergency medicine department. And these are classically that should be given to all the patients. Many times it works and sometimes it doesn't work. And the nephrology resident will be called to do emergency dialysis also many times. But the calcium gluconate should be administered in the 10% of it in 10 ml in IV infusion or IV route and slowly. And that can really reverse the blockade at the heart level. But it will not be useful again and again when you give it for more frequently. And the dextrose insulin has to be given with the 10 units of insulin in a 24% dextrose to be given over 10 to 15 minutes. And that also can reverse the changes of ECG. And the salbutamol inhalations, albuterol inhalation should be given, but the amount needed to control the hyperkalemia by the salbutamol inhalation is excess in such a way that the patient gets into complications like tremors and tremulousness. Very, very difficult. The furosemide can act temporarily. If the patient is on furosemide therapy for a long time, it can slowly and gradually control the potassium levels in the blood. The another resin available is the sodium polystyrene sulfate, the so-called Kexalate, and which is available in sorbitol free and in association with the sorbitol also to be given. But this is a huge amount of has to be given, which probably can produce it'll work like a laxative, but many times it fails to control, and not more than 1 to 2 grams it removes, and sometimes the marginal decrease in the potassium level can take place rather than a significant and a therapeutically valuable decrease in the potassium in the blood. So it will be always a difficult situation for us, and though we don't really go to the hemodialysis immediately to control the potassium in the blood, rarely, hyperkalemia alone may not be an immediate and the most important indication for initiating the dialysis, unless it is associated with some other complications like metabolic acidosis and refractory metabolic acidosis and uncontrollable pulmonary edema. But mostly we try to treat them with all this. So there is definitely a need for newer agents, and it is as the CKD stage advances from 3% in the initial 3 to 4% in the initial CKD 1 to 2 stages, but almost 15 to 20% of the patients with the chronic kidney disease in stage 4-5 would develop hyperkalemia. Interestingly, many of our dialysis patients would tolerate hyperkalemia when you take a first blood sample of the week and the pre-dialysis sample showing a hyperkalemia of more than 5.5 to around 6, but patients would be asymptomatic. But we cannot really leave them like that, because you know that the sudden cardiac death is seen in almost 20 to 25% of the patients on maintenance hemodialysis. That probably could be attributed to an increase in the potassium level in the blood. So hence, we are supposed to treat the patients and maintain the potassium levels to less than 5 in all the patients of CKD as well as on dialysis therapy. And moreover, as the patients are getting into chronic kidney disease progression, we are supposed to add ACE inhibitor, ARB, or nowadays even mineralocorticoid receptor antagonists also, like spironolactone and other drug therapy, where the potassium would be a problem for us to manage them. And in fact, initially when we were writing the ACE inhibitors or ARB, we used to tell the patients to get the potassium done once a week, week or 10 days later, and to get back to us again with the potassium levels. But nowadays, with the patients staying in distant, faraway places, it is very difficult to monitor the potassium also. It is not so easy. But the potassium level would be a problem in giving a very important and wonderful drugs called ACE inhibitors and ARB in the prevention of progression of chronic kidney disease in our patients. So it is very important for us to get the newer drug therapies. And unfortunately, all these drugs, whatever are available, can only temporarily deal with the transmembrane shift of potassium. And in fact, I personally do not really advise very frequently the resin sodium polystyrene sulfonate, and also never felt that it is so efficacious in controlling the hyperkalemia. And also this particular thing has to be given orally along with the sorbitol, and that was known to produce some kind of a colonic necrosis in some of the cases reported. So hence we require some newer drugs And luckily, we have few newer drugs which are supposed to be seen in our country. And the Patiromar, which was approved by FDA in 2015, not yet available in India. It's an organic, non-absorbable polymer, and which increases the fecal potassium excretion. It acts predominantly in the colon, and in exchange for the calcium, and the potassium will be excreted into the distal colon, and it works well as far as the literature is concerned. It is basically a free-flowing insoluble powder, and which has got a small spherical beads with a low viscosity, and which, when it is in the intestines, it tries to take out the potassium through that, and it is a tasteless, odorless powder and not metabolized or reabsorbed into through the GI tract. And there is a significant reduction statistically of potassium after taking it, ingesting it for around 7 hours later. And as the dose increases, the potassium excretion also increases. Is basically dose dependent increase in that. And it is to be given 8.4 grams initially to start with once a day, and maximum of 25.2 grams once a day can be given, and it should be administered routinely along with the 40 to 50 ml of water, and sometimes if required it can be given twice a day also. But no major adverse effects were documented with this particular Patiromar drug therapy, but there are some GI disturbances like constipation, diarrhea, nausea, vomiting, and excess flatulence have been reported in patients who received Patiromar. And a small percentage of group of people had a significant hypokalemia also. Along with that, the hypomagnesemia was also documented in this patient. And some patients probably had worsening hypertension, which I would like to tell you later. And the warnings, it binds not only with potassium and other things, but it also binds to several drugs which are concurrently given to the patients with a chronic kidney disease. And keep a gap of 6 hours whenever you are giving the Patiromar when in association with other drugs. But no robust data is yet available whether it can be used in those patients with acute life-threatening hyperkalemia. The Pearl HF study shows that when you compare to the placebo and other drugs, in those patients who are receiving spironolactone, the Patiromar was given 15 grams twice a day plus spironolactone and the placebo therapy. This is a 28-day study which is monitoring the potassium, and spironolactone was concurrently increased. It is only to see the change of potassium from the baseline to the end of study. This particular study showed a statistically significant improvement in the potassium compared to the baseline level, but hypokalemia was also significantly, along with the hypomagnesemia, was also significantly seen in these patients who received Patiromar in association with spironolactone. And another study, Amethyst DN trial, also showed the long-term safety and efficacy of Patiromar in outpatient patients with hyperkalemia. And we know that we have to treat hyperkalemia in the outpatient department only. This can be seen with a 4-week drug trial with a starting dose of 4.2 grams, maximum up to 16.8 grams taken twice a day, resulted in a significant decrease at the end of 4 weeks. And this also is supposed to be very important to see that the hyperkalemia can be managed on outpatient basis with the Patiromar. And another study, Opal HK, the phase 3 pivotal study design, also showed that the Patiromar in association with the RAS inhibition and placebo versus the placebo alone with the RAS inhibition at the end of 8 weeks showed 76% of the patients had reached the target potassium of less than 5 at the end of 4 weeks. And the recurrence of hyperkalemia occurred in almost nearly 60% of the placebo group compared to only 15% of the patients who received Patiromar. That shows that recurrent hyperkalemia is also important. We should be able to give this particular drug for a very, very long time. And as I stated earlier, the constipation and a significant number of patients having hypokalemia, of course, it is reversible, was seen in good number of the patients with the Patiromar. And time to first recurrent hyperkalemia was also documented in this randomized control trial after withdrawal, and that shows that 94% in Patiromar group continued to receive RAS inhibition, whereas only 44% could receive placebo therapy. 62% of the placebo group needed an intervention to manage hyperkalemia, whereas only 60% of patients on Patiromar would require some other intervention to control the potassium when it is a recurrence of hyperkalemia after withdrawing the drug therapy. So that shows that it's very important molecule that should be really checked in the future, especially when it comes to our country. Another important molecule which is there in the hyperkalemia management is the sodium zirconium cyclosilicate, and which is an inorganic polymer. It selectively attracts the potassium ion, its negatively charged crystalline lattice structure, and exchanges them for sodium and proton. and it is a free-flowing, again, an insoluble powder, which is sodium-potassium cation exchange agent. And this is also not systemically absorbed, and it should be given 10 grams orally, and it decreases potassium almost in an hour. It is a very quick in action. It has a 25-fold selectivity for potassium as compared to the calcium and magnesium, and it works throughout the GI tract. And the best results almost can be given when it's given 5 grams and 10 grams, and it should be administered along with the full meal, and it should be dissolved in 240 ml of water, and thrice a day with meals, and once a day if it is a chronic and outpatient management of hyperkalemia. As such, there are no major adverse effects have been reported or documented other than some simple GI disturbances and edema. And hypokalemia was also documented, which is again a reversible compared to pyrethromer. It was actually less. And the urinary tract infections and prolonged QT interval were actually documented, and also the worsening of hypertension was also documented. This trial, this harmonized trial, is a study where the sodium zirconium trisilicate was tested. It's a 48-hour open label phase with 9 to 10 grams 3 times a day, and a 28-day randomized phase. And primary endpoint was to see the change in the potassium compared to the baseline. And this particular study showed that the median time for the potassium normalization occurred in 2.2 hours only. And 84% of the patients normalized by almost nearly in 24 hours. And by 48 hours, almost really 100% of the patients got their potassium getting normalized. But some of these patients had GI disturbances. And hypokalemia was also documented. Compared to the placebo, hypokalemia was documented significantly in these people. And the edema, which is important to be noted, the numerically higher rate of edema was documented when the 15 grams dose of this particular drug is being given. The sub-study of this particular harmonized SF study in those patients with the heart failure, with the mean serum potassium over a time was checked, and these patients were on RAS inhibition and who achieved normokalemia in a significant way compared to the placebo therapy, as the doses were increased to 5 to 10 to 15 grams per day, and the efficacy also has increased further. And the normokalemia was maintained when 5 grams or 10 milligrams were given, and potassium levels increased to hyperkalemia levels in placebo group, but not in the particular ZS9 therapy. And when it is discontinued after 15 days, the hyperkalemia redeveloped within 1 week. That shows that it acts as long as it is being taken. And maintaining a normokalemia is very equally important, especially in those patients who have been taking RAS inhibition on outpatient basis. And compared to the placebo therapy, the maintenance of normokalemia was significant in these patients who received this particular drug therapy. And very important to know that this particular table almost summarizes what exactly is each drug, which is compared to the old one, which is the resin which is available to us. And the resin, all of them act predominantly in the GI tract, and they don't get systemically absorbed, and usually they get excreted into the feces. And as far as the selectivity of potassium is concerned, the sodium zirconium cyclosilicate is the one which has got the highest selectivity, and almost it binds 9 times potassium compared to the other drugs. And probably like pyrethromer, the magnesium binding is not associated in the sodium zirconium. And another important thing which you should remember is the edema and aggravation of hypertension in these patients who received hyperkalemia therapy. This is the sodium content of this particular drug therapy is 15 milligrams for sodium for 15 grams of resin, the sodium polystyrene sulfonate. Whereas the pyrethromer doesn't have any sodium content of it, but to remind you all that edema, the hypertension worsened in some small group of these patients who received pyrethromer, and the sodium zirconium almost approximately 1000 milligrams of sodium per 10 grams of dose of sodium zirconium. So that could be the reason why the significant number of these patients, almost 7 to 8% of the patients had edema and worsening of hypertension. And the sorbitol has to be given in those patients with the kexalate and pyrethromer, and which doesn't require to be given in sodium zirconium. You know that the sorbitol can really produce intestinal necrosis. And the onset of action is earlier with the sodium zirconium compared to the other drugs, and it also can sustain for a long time, but unfortunately we don't have a clear-cut idea about the duration of effect. But actually it acts almost for a longer duration, but the moment you stop it, almost 4 to 12 hours later, it can probably, the hyperkalemia can reappear. The doses, as I stated, it has to be given 2 to 3 times along with the meals and has to be followed up. And if it is, it can be given once a day, especially when you are giving the patient on outpatient basis. And all of these two powders are tasteless and odorless powder. It has to be mixed with water and it has to be given orally. But though hyperkalemia is a significant problem in our patients with a chronic kidney disease, but unfortunately, we don't have a wonderful therapy to manage these patients, and still an emergency management, something like a hyperkalemic periodic paralysis we have been seeing, and hyperkalemia as a number also will frighten the nephrologist when we see the potassium of 6.2 without much evidence of ECG changes, and we require to have wonderful drug therapies with the long-term safety and efficacy proven, and at the same time these drugs have to be given orally, and there may be some drug-to-drug interactions, and there can be less efficacy of other drugs concurrently given along with these drug therapies. And we don't have the efficacy trials done in those patients with a post-renal transplant where multiple immunosuppressive drug therapies will be given, and with a decrease in the kidney function gradually over a period of time, metabolic acidosis sets in these patients, and simultaneously the potassium goes up, and taking care of them would be a difficult thing. And as I heard that the cost effectiveness is also very, very important. And in these patients, and these two molecules which are not yet available in India are supposed to be very, very expensive, and we need to weigh the risk and benefit ratio simultaneously when we are treating with multiple drug therapies on outpatient basis. And most important is the dietary restriction of potassium, which is easily said than done and difficult to manage the patients at home. And we should advocate the potassium restriction, especially from stage 3 to 4 onwards, to all the patients where the significant number of these patients would be having hyperkalemia. And thank you very much for the kind attention and the patient hearing.